It's my distinct honor to welcome all of you, both those of you that are here in the audience in Tamkin Auditorium, and those of you that are joining us virtually, to our 2020 Closer to a Cure lecture series. The topic is actually adolescents and young adults with cancer. This is a really important group. They're not quite pediatrics, they're not kids, but they also have very different and unique needs and situations that they're facing that are different than older individuals diagnosed with cancer. So I'm so excited for you to hear from our panelists this evening, and hopefully you will have some questions that you can bring to the table. The Closer to a Cure's lecture series is actually a partnership between UCLA Health and the Leukemia and Lymphoma Society that was established in 2018 because there is so much hope and innovation happening in cancer treatment right now, and we wanted to be sure that every patient could benefit from it. So we have been taking UCLA doctors all over Southern California and having them share all the incredible innovations that are happening in cancer treatment and cancer care. So before we begin, I want to acknowledge the LLS Club at UCLA. So how many of you are from the LLS Club at UCLA? Raise your hand proudly. Okay, wonderful. For those of you that aren't here, probably a third of the audience raise their hand. The LLS Club is actually a new club that was formed by undergrads at UCLA who are pursuing degrees in pre-health and pre-med. So we're very excited to have this event in partnership with them. We are live streaming this event, and it will be archived online for future viewing. If you're joining online, you can actually ask questions. Just put your questions into the comment section of the online stream. And for those of you that are in the audience, we'll be passing out index cards. And you can actually write your questions, and then we'll gather the cards at the end. We'll have a Q&A at the end for about 20 minutes, so hopefully we'll be able to answer most of the questions. I also want to introduce our moderator for the evening. Alex Simoni is an undergrad at UCLA. He's a pre-med, and he will be introducing our panel. So thank you all so much.
Thank you, Shannon, and good evening, everyone. Let's have the panelists introduce themselves.
Hi and welcome. My name is Julia Levitt, and I'm a licensed clinical social worker, and I'm the AYA patient navigator at UCLA Health.
Hi, everyone. My name is Dr. Steven Spiker. I'm in the Department of Pediatric Hematology and Oncology, and I function as the program director of the AYA program here at UCLA. Thanks for coming.
I'm Jackie Casillas. I'm one of the pediatric hematologist oncologists here at UCLA, and I'm also the medical director of our AYA program here.
Good evening, everyone. My name is Bintu Kamar. I am the nursing director for the oncology service line here at UCLA Health, overseeing both our inpatient transplant area as well as our outpatient infusion clinic.
My name is Bryant Reese. I'm a primary mediastinal non-Hodgkin's lymphoma survivor and a future student at Yale University.
Hi, I am Racheli Peltier. I am a young adult patient advocate, and I'm also a campaign manager at the Leukemia and Lymphoma Society. And a survivor. I'm a Hodgkin's lymphoma survivor.
Thank you, everyone. Bryant and Racheli, could we have you elaborate a little bit about your patient stories?
Yeah, so as I said, still working? Yeah, so as I said, my name is Bryant. I graduated from Harvard Westlake School in Studio City this past June. And in July, completely unexpectedly, through an echocardiogram, I figured out that I had non-Hodgkin's lymphoma. From the point of that echocardiogram, I was sent to the hospital the next day, and I started chemotherapy within 2 weeks. I had 6 rounds of 5-day inpatient chemotherapy. I was super lucky from the point of diagnosis that everything went well. I didn't need any surgery or radiation, and December 15th of this past year, I was pronounced cancer-free.
I was 20 years old, and I moved across the country from Florida to Los Angeles to live the dream. And I was studying special education. I was in my junior year of college, and I came out here all alone. And I was sick for months, and I could not figure out what was wrong with me. Doctors would say that I either had a head cold or a chest cold or bronchitis. And ultimately, after 3 months of testing and follow-ups, I was told those 3 words that you never expect to hear, that I had cancer. And I immediately went home back to Florida so I could be treated by my family. I was staged 3B, which meant that it was on both sides of my diaphragm, and I had a lot of the symptoms to qualify for B staging, and I was set to receive 12 rounds of ABVD chemo. So every other week I would go in and get outpatient chemo. And through my treatment, I also experienced blood clots in my lungs, and I was hospitalized for that. But ultimately, with a smile on my face, I get to say that on November 12th, 2015, I was told that I was in remission, and now I'm 4.5 years cancer-free.
Thank you both very much. Let's move into some questions. Julia, the AYA population is composed of a very broad age range. What are the subgroups within AYA, and are there differences in the treatment experiences within these different subgroups?
So NCCN and NCI designate that age range that we're talking about is 15 to 39 years of age, which is a large age range. And I look at that as different developmental milestones that we face during that time in our life. And whether it's finishing high school or going off to college or your first interpersonal relationship, marriage, entering the workforce, those are all huge different things that could be happening, and those are all different subgroups to be considered when treating a patient. So where are they in that period of their life when they enter our health system? Another subgroup is whether we're treating them in a pediatric setting, in pediatric oncology, or in the adult population. So those are what we're thinking of in the health system, and really what's happening to them as they explore their development and how autonomous they are, coming into a place that's going to take away a lot of their control.
Thank you. Dr. Casillas and Dr. Spiker, what do you find are the most important things to discuss with a cancer patient who is an adolescent or young adult?
So there's a lot of things that we have to bring up when we're meeting with a patient for the first time in this age group between 15 and 39. Obviously we're going to have to talk to them about their treatment options and all the different options that are there on the table for them. But unlike our pediatric and some of our older adult populations, there are some really distinct needs that these AYA patients have. And in kind of vamping our AYA program here at UCLA, that's what we've really been trying to hit on, is how do we address those AYA-specific needs in a very timely manner for this specific population. So some of those needs that we want to make sure we address with those patients include mental health. We really want to make sure we're addressing their mental health needs. Another one is clinical trial enrollment, knowing that they're not necessarily enrolled in clinical trials as much as we would like to see them enrolled in those studies. Another one is fertility preservation. Financial security is another one that we really know that there's really a disparity in their needs. So when thinking about that population, obviously we think about their treatment, and as an oncologist, that's a huge part of what we do, but then we know that we also have these other really important aspects of their cancer journey that we have to really address. And we also know about this is that we have to be addressing those throughout their entirety of that cancer journey. It's not just at the time of diagnosis, but it's throughout their treatment course. It's into those final days of the treatment course and then beyond. And it's how do we do that as a health system? How do we really identify those needs, address those needs appropriately in order to really take care of these patients to the best of our abilities?
And I would just highlight, what's so important, like what Stephen was saying is, really when we're sitting down with the patient, you want to talk about what is your treatment options. And I think one of the things that's really critical that a lot of my patients will ask when you have that new diagnosis treatment talk is they ask me 2 things. One, it's overwhelming that you've been diagnosed with cancer, but how long am I going to be in the hospital? And when do I get to go back to school or work? Because it's that eye for the future. And so explaining, how the infusions are going to go and really having access to clinical trials, because like Stephen had highlighted, it's so critical because The reason the NCI, our big National Cancer Institute, defines AYAs as having disparities in their care is because our survival rates can be lower, as well as our toxicities to treatment can be higher. So really understanding why is that, and clinical trials give us that opportunity possibly for new treatment options, but also following the patient long term. And in addition, I think it's important to highlight, like Dr. Spiker said, is, it can often be when you're talking like, I just want to be in my room and I don't want to reach out to other people, but it's so critical to be able to have access to all those resources, whether it's through peer support. There's a lot of community organizations that do that. The social workers and our psychologists that are part of our program here, all of the great work Julia does to make sure all of the identification of the resources. And then, many times when I'm having those talks, people want to know, when am I going to be through this? And, I say that, becoming a survivor starts at time of diagnosis, and that continues through the whole continuum of care. And, having many times when I see them in my survivorship clinic, they're saying having that hope for cure kind of gets me through it. And so, being upfront about, all of the tough parts of the cancer treatment, but then also knowing that, we have the ultimate goal to get through treatment and then get people back to their life before we had to kind of hit the pause button in the hospital or in the outpatient, setting for treatment.
And as a follow-up question, Dr. Casillas, your research focuses on the quality of life for young cancer survivors. How has that research impacted how you treat your patients today?
I think from a really practical perspective, because I do look at quality of life and ultimately quality of care, making sure our young people get the care that they need. But I think one of the most important things that my patients and my research have taught me is that, don't make healthcare my full-time job. This is not the gig that I'm signing up for. But, we have to be partners in that care. So even after cancer treatment stops, because many things during cancer treatment you don't have, because we have protocols that are telling us like we need chemo A versus chemo B, there may not be those choices in terms of regimens, because we may say, well, this is really tough chemo and it's all inpatient, but we know it's going to be the best chance for cure, so we really have to do that. But having a conversation about, if there are those life events that you want to go to, sometimes working around prom or when can I was supposed to go to college and can I do online classes, if you're feeling up to it when you're going through treatment. And then in the survivorship phase of care, it's really critical because we do have this balancing act where we're looking to make sure that the cancer's not coming back, this assessment for disease recurrence. But because we use really aggressive treatment regimens, there's also this risk for late effects or health problems secondary to the aggressive chemotherapy, radiation, and surgeries that people go through. So when you get into your survivorship phase of care, kind of prioritizing, there's a lot more scans and imaging, it might be an echo, it might be these other things, but trying to work within the context of patients' lives, and I think that's really critical. And then the other part is that, like Dr. Spiker said, fertility starts at time of diagnosis, but it's something that we want to continue with those discussions, because that other topics about the impact that cancer has had on your life can also come at different phases, even after the treatment stopped.
Dr. Spiker, are there big differences in the health outcomes between pediatric, adolescent, and young adults? And if so, what can account for that?
Yeah, so it's a great question. What's amazing is over the last, really 50 years, we've done some amazing things in regards to our advancements in the care of anybody with cancer. Alec, can you actually hit 2 slides, 2 down?
Sure.
It's on the thing. Next one. So I think this graph is a really good illustration of the why of this program and really looking at that survival advantage that we're seeing. What's amazing is if you look to the left, you can see in that pediatric population, what we're seeing is an amazing improvement in the survival of these young pediatric patients. And when you look to the right, what you're seeing is in our older adult population, they're seeing a similar advantage. And what you're noticing in the middle is that you're not seeing that same survival advantage that has been seen in this AYA population. population. And when we really think about the why, because what you're getting at is, well, why is this happening? There's a variety of different reasons. And I think that Dr. Casillas hit on a couple of different ones. One of the big ones that I think of is the clinical trial enrollment for these patients. We really don't understand their disease fully to be able to understand why they aren't necessarily responding to treatments as well as maybe our pediatric or adult populations. Or, is there a 20-year-old patient that really should be treated from a pediatric regimen, and right now they're being treated on an adult regimen? So that might be part of the why. Some of those other things are related to some of the more psychosocial impacts that Julia tries to address. So compliance is such a huge part of the cancer journey. We're asking a lot from these patients from the time they're diagnosed. We're asking them to be really diligent with their lab draws and with their medications and making sure they're taking everything on time. And it's a big ask. And I think that in this age group, they're at a lot of ways, Dr. Casillas was saying, they're trying to just live their life. And so it's a challenge to try to engage them in their medical care in a way that makes them realize that it's so important for them to be taking these medications on time. So we are seeing this lack of an improvement in their survival advantage of this specific population. And I think it's one of the main reasons why we've realized the importance of really dedicating resources and dedicating a service line specifically to this AYA population.
Thank you. Bindu, what is the significance of the nurse's role in treating with AYA patients?
Thanks, Alec. Nursing really plays a pivotal role when it comes to healthcare in general. But when it comes specifically to the AYA population, we're very unique in that we're looking at the holistic approach. So we're not just looking at, we have the beauty of having all this clinical knowledge thanks to our other healthcare colleagues, but also now we can look at other means that makes AYA thrive at their developmental age. So there are psychosocial needs that we're wanting to focus on. We're wanting to understand, well, how are we going to increase compliance, and more importantly, how we can cultivate the relationships that their offer are suffered from. With the AYA population, they're taken away from their normal environments, whether that be in the school environment, whether they're in a career or a relationship with their friends or their peers or colleagues, and of course, intimate relationships, whether it be their partners and other siblings that they may actually have relationships with. And now they're kind of bogged down by a schedule of treatments coming in for whether it be weekly or daily infusions, or staying blocks of time in a hospital setting where they're pretty much quarantined. So we are the best people to kind of go to the bedside and try to normalize what's going on. We learn a lot from our AYA population and understanding where they're coming from, their stories, what experiences they bring with them, what preconceptions they come with, because they may have a parent or a sibling or a friend who's gone through something similar or any other kind of illness, and what does this mean for them? It gives us insight as to how we can foster that understanding and share our stories as clinicians, but also advocate for them with the rest of the multidisciplinary team as to where they're coming from and how we may need to change our priorities. Yes, there may be regimens and protocols that we do have to follow. Those are sort of non-negotiable. But how can we stage it, if you will, around what's meaningful to them, a friend that's visiting, or a movie that we can probably play in the unit that other AYA folks can look into. When I visited some AYA units in the UK, it was very telling to know that there are infusions that we could do at 10 o'clock at night because, hey, that's when the movie ends, and why not? And maybe some of the side effects we don't have to suffer all day with. Giving it at night, we can, get them through the night and still be living and doing all the normal things that adolescents do during the day. So it's working around what we can do, and sometimes we as nurses kind of can facilitate some of that, work with our physicians and say, well, we are off an hour or two here, or, we can't make it Friday, let's make it Saturday. It's what we can do. And being here at UCLA Health, we also have a 7-day infusion clinic here, and having that weekend and evening availability allows our AYA students to go to school or do online courses and offer ways in which that we can amalgamate the two worlds and hopefully build compliance but the advocacious role that we have and the ways in which that we can make it real helps us a lot. So thank you.
A more personal question for Dr. Casillas and Dr. Spiker. What led your career to focusing on adolescents and young adults with cancer?
So for me, it was really twofold. Every day I'm grateful that I'm a physician, but it was really the patient bonds that inspired me, as well as the strength and just having that hope for the future. So really the bonds that I formed with the patients were really what really has my passion in the AYA, but also because I'm also a researcher as part of my role as a physician here, and the opportunities for research. When you go to the NCI and you go to these meetings and you hear that you can have a 95% chance of cure for leukemia, our most common form of leukemia, for a younger child, and then it goes down to 65% for a teen or young adult, like understanding why is that. And it's it's also a science that continues to evolve. And I think that, making sure that we get access to those clinical trials and, understand what are going to be the newer agents for cure. I have many patients as survivors who were treated many years ago, like for Hodgkin's, and we didn't even have people had to get their spleen taken out to know if they had Hodgkin's disease there. That sounds like really crazy right now, that you take out an organ to see if the cancer was there, because now we just have, but we have, imaging that we look to say, is it involved or not? And then, having patients pass away as survivors from an infection because they didn't have their spleen. And that, kind of sounds like, the wild, wild west, but it wasn't that long ago. And, now having, clinical trials and having access to these targeted monoclonal antibodies in the context of being able to provide this for patients, and then, seeing them, just, it sounds kind of like I'm an old lady, but grow up and meet all their life, all their life events. I love it when I have my patients coming back and, coming back to my clinic and they have their babies and they're like, Dr. Casillas, they tried to check in the baby, but I'm the patient. And, those kind of things, that combination of just having an amazing group of patients as well as having continued access to improving, survival rates for the patients, and it continues to evolve, each year. It's really quite an amazing time.
Thank you. Yeah, for me, when I was going through training as a pediatric resident and into my fellowship, and started to really notice these disparities for this age group, I thought to myself, I'm in that age group. And what would happen right now if I got cancer? If I, as a pediatric oncologist, was diagnosed with cancer tomorrow, which of these things would I actually have in place? And I realized that I'm just like everybody else that's diagnosed in this age group. And I would have a similarly really difficult time coping with the fact that I was going to have to undergo all these treatments, and similar financial distress with all of my student loans and trying to figure out how I was going to pay for my therapies, and similar issues related to how do I continue to move on in my life while I'm, doing this right now. And I think it was that realization that this was a very needed service and a huge need within the entire health system and within the entire health system, more broadly. And finding a way that I can potentially be impactful in this age group was really something that drove me to wanting to make this a strong program and a strong emphasis for something that we can do here at UCLA Health, and then hopefully more globally as we continue to broaden the knowledge of this AYA specific need.
Thank you both. A question for Raheli and Bryant. How has your cancer diagnoses affected your relationships in life, such as friendships, family, significant others, and dating?
Yeah, so I was incredibly lucky that I had two awesome parents and great sisters that were super supportive and there with me the whole way, and a girlfriend who was awesome the entire time throughout my treatment. So I would say that kind of that inner circle, obviously everyone's under a ton of stress. You don't know how to deal with someone who's just been diagnosed with cancer. There's knowns and unknowns that you have to deal with. But that inner circle, your relationships don't really change because you're close to those people. You're communicating with them every day. But I would say where kind of the change in relationship comes is with your not so close friends or the people that you see at the grocery store, at school or whatever, you've now solely become to them the kid with cancer. You don't have your hair, you look different, and they're scared and they don't really know how to handle it. And while everyone's trying to be nice and gracious to you, and they are, they don't really know how to handle it. And you don't really know how to handle it, and it's something new and momentous in your life that you don't know how to handle, and so it kind of becomes the center of your life, and you can't really get back to just a normal conversation with someone, I would say.
To piggyback off of that, with people not really knowing how to handle a cancer diagnosis, especially as young adults, I feel like our friend groups didn't know how to respond or act or care for us. And it was amazing to see how the people that I expected to be there for me kind of weren't. And it's okay, because now that I'm so far out of it, I've learned to forgive and accept and realize that it must have been so shocking for them. But then to see the people that I never expected to be coming to chemos with me or texting me every day, seeing how I was feeling, kind of came out of the woodwork. And I wasn't expecting that. So it's kind of like a whirlwind to even see how people respond. What an experiment, let me tell you. But then when it comes to my family, that's a shock to your family unit. So as much as we wanted to be there and support each other, and even me wanting to support my mother, who just had to find out that her baby girl was diagnosed with cancer, we did the best that we could under that stress. And even post-cancer now, it still affects us daily. Like, I live across the country from my mom, and she has this PTSD of the first time that I moved out here, I was diagnosed with cancer. And now every time I'm on the phone with her and I have a tiny little cough or something, she freaks out. And understandably to her, because that's just all she can remember from that and all she's worried about. So it's deeply affected all of us individually in our own ways. And unlike Bryant, I did not have a boyfriend while I was going through treatment. So I was also navigating kind of dating and going on dating apps while I was going through cancer. And that was a whole adventure of itself. And then dating after cancer, which, welcome to that, was very interesting. And it kind of put things into perspective for me, while I was going and meeting new people and what I wanted to share and how it affected what relationships meant to me. So yeah.
And a follow-up question, in dealing with social media, how much did you personally decide to share about your cancer experience and story, and what were the positive and negative outcomes of that?
So I'm gonna go first. Okay. Well, I shared it all. When I was told that I had cancer that night, I decided that I should make a video blog and put everything on YouTube. So I took out my phone and I started recording everything. And it was really all about, for me, to share with the people that I loved what was happening. Also worked as kind of like a diary for me, a visual diary. And I wanted to help other people because I looked up online when I was diagnosed. I'm 21 and I have cancer, and there really wasn't much out there. And so for me, I wanted to share something in the internet space and kind of talk about how to overcome adversity with positivity and mindfulness. So I made this video blog and I recorded literally everything, like my chemos, my testing, my PET scans, my bone marrow biopsy, like everything. And then I also went onto Instagram and I started sharing on there. And I didn't really used to post much, really about my like really deeply personal stuff. But this became such an outlet for me. And there weren't many negatives that I can recall, except for when it came to meeting incredible people and then, them passing away, like getting so connected to these people who I've never met in my life. I guess that would be the negative part of it. But for me, it was a really positive experience. I gained friendships from it. A few of my bridesmaids in my wedding post-cancer were actually women that I met on Instagram who went through the same thing as me. And we just forever have that bond. It has also served for me as a diary, which I think is really important, to journal and have gratitude lists and things like that. And I just put that out in the universe. And yeah, so that was the positives for me. And we're going to flip the coin and share another part of it.
Yeah, so I had pretty much the opposite experience. prior to my cancer diagnosis, I didn't post a whole lot on Instagram or Facebook. I was more of a content consumer than a producer. So I didn't kind of, in an attempt to normalize life during cancer and life after cancer, I didn't really see a need to change that. And I completely understand that it is an awesome outlet, and it may have been a great idea for me, but kind of within the moment, just to survive day-to-day life and kind of keep moving forward, there were so many things that were changing within my life at the time that I didn't really want to change the social media aspect of it. And I felt like just continuing on my same path was the best way to just get through.
A question for Dr. Casillas and Julia. There are many issues in fertility as a big concern within the AYA cancer population. What are things you discuss with patients about fertility?
We here at UCLA find that this is a conversation that is an ongoing conversation, and our goal is to have this conversation at diagnosis, that your fertility might be jeopardized due to your cancer treatment. And for many patients, they have not thought about the future of having children, and maybe for some of them, they've just been thinking about how not to have children for the last 6 years, and that's okay too. And how do you manage hearing the words that I might not be able to have children, I also just got a cancer diagnosis, and I need to figure out who's going to get me to my port placement on Friday. And so this is a conversation that happens with multiple providers, from your oncologist to your nurse to your social worker. And then also there's a lot of, it's multifactorial in the fact that there's a financial aspect to it. So a big part that I play in this is working with our patients to find the resources, and there's wonderful organizations that exist to help fund young adults in preserving their fertility. We've also, with our new program here, have really streamlined the process to work with our reproductive endocrinologist, if you're a female, and set up that consult so that it's even just having that conversation, because maybe it's not something you want to do at diagnosis, but meeting another physician who's a specialist in that area, who's not your oncologist, and to know what it would be involved, and then knowing that that door is open to come back after treatment. And the same for our male patients, actually working as a liaison to help with sperm banking at the California cryobanking, and then after, if it's not an option at diagnosis, working with the men's clinic here to see our physicians in urology. But we really are very passionate about having open dialect and having that conversation from diagnosis, but then throughout the trajectory of treatment.
Yeah, just echoing everything that Julia said, and I think, just having the discussion multiple times, we know that from long-term research studies that if a patient who's a teen or young adult doesn't hear about, at least, there's so much information, but if they feel like they did not hear about the risk for infertility, that impacts their long-term quality of life. So, because there's a lot of anger associated, like I didn't get the information when I needed it. But then at the same time, when you're delivering this information, it's such a sensitive area. Many times if people were independent, and then they have to move back home and be with their parents who are at the bedside, and you're getting all this information, and we're like, well, for men, you have the opportunity to do sperm banking, but what does that mean? And all the logistics of that, and then having a family member drive it over to the cryobank, all of these things, I have some teenagers that are like, I'm not even doing it because I'm not there, but you have to have these very detailed discussions from the practical perspective, as well as with females, like what does it mean, like I'm going to have less eggs or possibly go into early menopause when I'm not there. So it's a lot of information up front, but important discussions to deliver, I believe very sensitively, because sometimes, talking with, a teenage guy who may not have had a sexual relationship up until that point, and then we're saying, now we have to bank your sperm, like that's too much, just leave me alone, but wanting to make sure they have every option. But then it comes up again when I get to see them as survivors, because many times, I say we may not know your fertility status. So one, make sure that you have safe sex practices, because I don't know, if you're going to have an impact on this. There's a high likelihood based on X, Y, and Z chemotherapy or radiation to the pelvis. But they say, I don't really care. I don't want to have kids right now. But it might come up again when, wow, I'm really thinking about maybe marrying this person or moving in. And then you get, for some patients, you may do a semen analysis for a male, and then they find out that they're infertile. And I've heard people say, you've told me some pretty bad stuff about cancer and all the side effects. This is probably the worst thing, because then again, it's like a loss. Like now you've taken away something again years later if they didn't know their fertility status. But then having the patient navigators to get to resources, there's all different ways to make a family, whether it's going through fertility preservation or assessing for that, or adoptions or surrogate. There's so much out there, and it's different choices for every person. So just making sure it's a continuing discussion, it's delivered very, I believe, gently, and here you have a brand new doctor talking to you about all these things, and it takes time many times to just process all the information. But just, I always tell people, you may not remember everything now, but just know we have this discussion. So if something comes up in the back of your mind, just say, hey, I want to come back in and talk about it some more. So I think that's really critical, and knowing that there is, so many different options. If infertility is what has been an impact, is what we call a late effect, or a health problem that's a direct result of your cancer therapy, but just knowing that there's options out there.
Raheli, as a former patient and now survivor, what was it like being on the other side of that interaction?
So, like Julia and Dr. Castilla said, it is an ongoing conversation with your doctor and healthcare team. And it was something, I know I said I was single when I was diagnosed, but I knew that I wanted to be a mom. And that was one of my first questions going in to meet with the oncologist. And it was an ongoing conversation. We had it almost every time that I went in before I started chemo. Unfortunately, I did not, and I mean, not unfortunately or unfortunately, but I did not end up saving my eggs or freezing my eggs, but it was a long conversation. And, what went into it is that, I would have had to wait an entire cycle, but I was diagnosed really late, and they wanted me to start chemo pretty immediately. So we did not go through that process because of that, and then also cost. Unfortunately, health insurance doesn't cover egg freezing and the reproductive stuff. So that was a really hard thing for us to make that decision, because my mom is a single mom, I was a college student, we just weren't in that space and didn't have those resources. So that was our decision. So it continues after treatment, that conversation. Me and my doctor were, tracking my cycle, making sure I was getting back to a regular cycle. When I go to see my doctor, we also test my hormones to make sure that my hormone levels are fine. And we're kind of tracking it in a more holistic way, I guess. I still live with that sometimes, where it's like I'm scared to know if I can or can't, but I know, with my overcoming with my mindfulness, I'll know that whatever happens, we'll figure it out, I guess.
Thank you so much. Julia, when it comes to physical intimacy and sex during and after cancer, what questions or concerns do you often hear from patients?
Thank you, Alec. I think that's a great follow-up question and a very important question. I think that natural sexual exploration is very important during this development when we're talking about this age group of 15 to 39-year-olds. And many patients don't necessarily feel comfortable speaking to their oncologist about some of the questions they might have. For example, when they're on active treatment, can they have sex with their partners or someone they're dating? And so I really try to foster a safe environment to explore those conversations with my patients, as well as the effect of a patient's self-esteem based on the outcome of treatment, whether it's their own experience with body changes that happen, and will my partner continue to find me attractive? Will anyone ever find me attractive with the changes that have occurred that I have to live with for the rest of my life through after treatment? And then also many patients will talk about how it feels to have sex after treatment and that it's not comfortable. So then I do my best to refer them to other subspecialists and normalize that this is something very common for other cancer patients, that they experience this as well, and that we have specialists that can speak to them and help them with this, and that they should not feel isolated. And then I also try to model and role play with them to have these conversations with their oncologist, to feel comfortable having them with their oncologist, who can also make those referrals to the subspecialist for them.
Thank you so much. A question for Raheli and Bryant. How has cancer impacted your education and professional life overall? And as a follow-up question, people often struggle with how much they should share about their cancer diagnosis at work and school. So what has been your approach towards that?
So, like I mentioned, I was diagnosed going into my senior year of college. I was studying special education, and I really wanted to be a teacher. And when I was diagnosed, I stopped school, and I took that time off. And through all of that, I discovered that I don't want to be a teacher anymore, and that I wanted to do something in this cancer. This keeps going in and out. I wanted to do something in the cancer space. I wanted to continue to be able to be a patient advocate. So I started doing a lot of work in that, and I was, continuing my videos. I was partnering with other organizations and doing keynote speeches. And through my online presence, LLS found me and asked me to be a guest on their podcast. And I think that was kind of like the epitome of my life. It was how my life changed professionally and with what I wanted to do post-education. And I did the podcast. I was actually the first guest. You should go listen to it. It's called The Bloodline, Life on Pause. And then a wonderful human named Shannon. Can you hear me? Okay. A wonderful human named Shannon found me. She's actually in the back of the room. And I started thank you. I started volunteering for LLS, and I was working odd jobs. I was a nanny, and then I worked for a beer company, but I still kept volunteering for LLS and continuing my patient advocacy work online and through public speaking. And then I did a campaign called Woman of the Year through LLS. Shannon nominated me, and I figured out that I'm obsessed with fundraising, speaking about my cancer journey and continuing to be an advocate. And I realized that I could do both of those things while working for LLS. So now I have a career at LLS. I'm a campaign manager for Light the Night, and I'm just so excited to grow with the organization. And I guess thank you, cancer, for giving me this incredible purpose and mission. And I get to wake up every single morning just loving what I do and having purpose with that. And I could cry. It's so great. And your follow-up question?
Right. The follow-up being essentially, how do you handle talking about that diagnosis at work and with friends or at school?
Obviously, I'm an open book about it. Before I actually worked in the cancer space at LLS, I went to a conference called Cancer and Careers, which is a wonderful organization that is for young adults, or really all ages, but it's specifically young adults because it's about how to go back to work or how to apply to new jobs. They help you form a resume if you have a big gap in your resume, and I found that really helpful, and it was all about navigating those conversations, like when you're applying, what is that gap? Because you don't necessarily need to tell employers about your cancer experience. For me, though, I kind of took it and flipped it and made it why I would be so great for a position or a job and why it's impacted my life in a positive way. So I talk about it a lot.
Yeah, so my cancer diagnosis was obviously super impactful on my educational experience. I was only a month removed from graduating high school and a month from going off to college and living on my own for the first time, which is normally a super exciting time period for an 18-year-old boy. But obviously in July, that all changed, and I'm now on a gap year and luckily cancer-free and everything. And obviously cancer was the main priority my entire fall. But it definitely had a big impact. There were 300 kids in my high school graduating class, and 299 of them got to either go off to school or wherever their experience was, and mine was kind of chosen for me and not exactly what I wanted to do. I never anticipated myself taking a gap year. So, and also I'm still planning on, but I was going to play baseball in college, and so having cancer has a hopefully not too big of an impact, but a huge impact. I've noticed it as I'm starting to work out again and try to play baseball again, that I'm clearly very out of shape. You wouldn't think so, but 5 months of not doing anything and sitting in hospital beds and getting chemotherapy isn't very good for your physical condition. So it's definitely a challenge, I would say. And your follow-up question was?
So what was that conversation with your peers like, having to discuss your diagnosis?
Yeah, I'm obviously only 2 months removed from actually finding out that I was cancer-free, so I haven't really had too many experiences professionally or educationally with interacting with new people who didn't know that I had cancer. But I have found that as I'm interacting with my friends, and kind of like I was talking about earlier, those people outside of your inner circle where you were kind of the kid with cancer during treatment and whenever they would see you, kind of, I have noticed that as I've gotten my hair back and gone back to normal and kind of normal Bryant, that all those people, your relationships kind of naturally go back to normal, which is a super positive thing.
It's great to hear. Julia, are there challenges that you see within the AYA population when it comes to education and careers?
So like our panelists spoke, I see all sides of the spectrum. I see for all of the patients that I work with, I think they would all agree that they, at some point, whether they put their education or their careers, they press pause. And so how do they find a way to get back to whether it's finishing their and graduating from high school, or finishing and getting their college degree, or re-entering the workforce? And for many of them, they're still exploring what they want to be or where they want to go off to school. And so with that, it's finding their identity and building back that self-esteem. And finding the finances to finish a degree. And for some, that was, spoken about, it's cancer reshapes what that identity is and maybe total change in career paths. So helping them to explore all those opportunities, and there's wonderful organizations out there that also provide a lot of resources for this population to help do that. We also work with some great tutoring companies, and also just having these conversations and connecting our peers in our program with each other, that maybe someone who's gone through this already, and providing that normalization that, yes, you did have to take a couple years out. And I think another challenge for a lot of our young adult patients is some of our patients whose course might be more complicated, where they've gone through treatment and then they face a relapse, and so they've gone back out into school and then have had to take time off again, or they've gone back to work and they have to explain to an employer that I have to go back on treatment, so I need to take more time off. And so how to work with them to find the courage and strength again to get back out there and go back to work after the significant times off back and forth.
So Raheli and Bryant, there's a lot of talk about returning back to a normal life after cancer treatment. Do you have advice on what that's like and how to find essentially a new normal?
Yeah, so I think kind of as I was saying earlier, I've been pleasantly surprised that seems to be happening relatively naturally within my relationships, but I think it just takes a little bit of time. Like, obviously, my physical condition isn't going to come back right away. My hair is not going to come back right away. People who I haven't talked to in a while, that relationship's not going to come back right away. But as time evolves and as I'm having more interactions or more workouts or stuff like that I feel like it's coming back to normal pretty naturally, which is a good thing to hear. And I also think giving myself a schedule has been really helpful, because during cancer treatment, you have a schedule. You're going in for blood work this many times a week at this time. This is when your chemotherapy is. It's for these 5 days, and then you have this exact number of days of rest. Your schedule is you have a very kind of tight schedule that you have, and I feel like giving myself a schedule, like I've started an internship, I have specific times when I'm working out, giving myself that schedule, so hey, you have to get up and get going at this time, has been really helpful to kind of giving myself a normal schedule as opposed to my cancer schedule, has been super helpful to reaching that normal life.
It's great to hear.
Yeah, so for 9 months while I was going through treatment, I thought that my last chemo would be the end of cancer, and I was putting it in a door, and then I was walking out, and it would be my old life again. And in a lot of ways, that is what happened, but in a lot of ways, I also had to rediscover, like you said, it's a new normal. And there are so many new things that I've learned about myself and the people around me and the way the world works. And I think that survivorship is also a really big part of the cancer journey. And my biggest piece of advice would be to embrace it and to kind of make it something new and normal for yourself, I think. Like, I feel like I love harder and I feel harder now and I care harder, and that's just become a new part of who I am. And there's also a lot, you mentioned earlier about toxicities, and so I unfortunately experienced lung toxicity due to one of the chemos I received, and those kind of long-term side effects are a part of my new normal that I'm realizing, a part of other things, like I have Raynaud's now, hypothyroidism, and some other health issues that still linger that are manageable, and they're not cancer, thankfully, but they're things that play into who I am now and what I choose to do with that. So I still have to go see a pulmonologist now, whereas before I had cancer, I never had to do that. And yeah, it's just an adjustment, and it's making sure that you're finding organizations and groups like UCLA has to prepare for that new normal and that journey through survivorship, because there's a lot of mental and emotional aspects to it too, with PTSD and all of that. So it's very, very important to be prepared and to embrace the change.
Our last question before we open it up to the audience for questions. Julia, what are some of the mental health and wellness challenges you see affecting adolescents and young adults with cancer?
Sure. So we talked a lot tonight about the unique challenges that this population face, and with those, if we think about coming into a health setting where you're a young adult and you were living your life autonomously, maybe it was the first time you were living away from home, starting to form your own morals and ideas about life, and you were really excited about being in school or having your first job, and then you get this diagnosis and you now have to start trusting strangers and taking medication that may make you feel really crappy and being away from your friends and missing out. It's very natural to start to feel depressed, to feel anxious. You're experiencing body changes. With that can come self-esteem changes. So it's very common that as a medical team, we watch and we see that happen. And we have professionals like myself and other members of our team that are there to assess for those changes and to support our AYA patients, whether we make referrals to other mental health providers here at UCLA, at the Sims-Mann Center, or to psychiatry, and or to outside providers. We also run peer-to-peer support groups. We work with other great organizations. LLS runs wonderful online support groups if coming in person isn't something. Teen Cancer America supports wonderful meetups for patients. So that's what we're constantly doing, but it is not something that we normalize it as providers. It's not something that we find to be something that's very destructive, and we work with the medical team and to create a treatment plan for our patients.
Great, thank you all so much. We're now going to open the floor up to an audience Q&A. We already have some questions from the live stream that are funneling in and from the current audience, but just a quick disclaimer, please keep the questions objective and respectful of the privacy of the survivor panelists. Just want to make sure that everyone Great, so first question. The AYA population is often called the forgotten population, as represented by your relative change in 5-year survival slide. With 70,000 AYA patients diagnosed a year, why is it that the NCTN does not design trials, both clinical and psychosocial, for this age group? I guess that would be a question for Dr. Casillas and Dr. Spiker.
I mean, no, it's a great question. I think one of the big issues with designing trials for this specific age population is how fragmented it is as far as where these patients are being cared for. What we have at UCLA, which is an incredible opportunity, is we have patients that are being treated from birth really to, into their geriatric age group. So we have the ability to see patients across that continuum. A lot of places throughout the country, pediatric patients are being treated in children's hospitals, and maybe you don't have the older adult populations to actually run those trials there. A lot of these AYA patients are also being treated in the community, and a lot of times in the community, it's much more difficult to run some of these, higher volume clinical trials. So really, we need to make an initiative across the board on funding these trials specifically for this age group, and then also doing a better job within our health systems of getting these patients into those clinical trials, really engaging those patients from the get-go and finding out if there are clinical trials they'd be eligible for, and then getting them in to better understand the disease and better really kind of define this specific age population.
As a follow-up question, why do you think it is that insurance sees fertility preservation as a luxury and not a right, and thus it's not covered?
Don't get me on my soapbox. It makes me so angry. But I know there's been, within our AYA provider network nationally, there's been a lot of work that has gone into trying to advocate the need for like the big blues, like, we were talking earlier that, just like you wouldn't deny a nausea vomiting medicine for someone going through a chemo that's going to give them nausea and vomiting, why is it that you can't pay for the fertility preservation as well as the options afterwards? And I think it's a cost issue. It's continuing to be something that's advocated at the national level. There's like I said, there's specific researchers working on it, advocacy groups working on it. And I think that, the biggest problem that we have, and, not trying to get too political, but, healthcare is super expensive, and it's just one more cost adding up to how expensive cancer care can be. And I think that, we're just going to have to continue to push for legislation, whether people are for or against different types of health care that's provided by our government. I do know the impact that when, Obamacare, and, he owns it, but when the Affordable Care Act came through, it made such a big difference because it took away that pre-existing condition to be able to get affordable health care. And so I think, just continuing to advocate and legislate for that so that it can't be a carve out. But the other part that I think, particularly practicing in California, we're very, very fortunate with public insurance options up to the age of 21. After 21, I think it gets harder with our Medi-Cal options, but many times people may not, we get our insurance through our providers through our work for the most part. Now you can buy options, through the Affordable Care Act, but, many people are going to pick the most reasonable option because they don't want to spend their monthly check on health insurance, and then you don't expect to get cancer. And so there could also be, carve-outs about what's covered. So I think, just ongoing legislation, I think it's an exciting time, just continuing to advocate from that patient voice perspective.
I just wanted to add that for the state of California in October of 2019, Governor Newsom did pass a bill that if you have private insurance and have a medical condition that will cause infertility, your private insurance will have to cover some of your fertility preservation. But what I have found with the patients I've worked with since then, it is a lot of advocating on the patient's behalf that even those private insurers aren't even aware that they do have to cover that benefit. But I do agree that it is a step in the right direction, and being fortunate that we live in California and have a governor that is going to legislation and advocating for our patients.
A question for all the medical professionals. In your personal experience, do you find that chemo or radiation is more responsible for issues with infertility? And also, how are those issues arise?
So it's a combination. So it's a really important question, because if I see a patient that comes into my survivorship clinic about their risk for infertility, a lot of the work has actually been led by the pediatric long-term survivorship studies, where we follow patients and have large groups of patients that we followed into now kind of going into their 40s and 50s. So It's a combination of both. I always tell people that, even if you have, the same diagnosis, your risk for like infertility or other late effects or these health problems from cancer treatment really depends on your exposures. And so there are certain chemo agents like classes called alkylating agents at high doses that put you at higher risk for infertility. In addition, if you have radiation to your pelvis as a female, there may not be options for trying to kind of shelter your ovaries, so to speak. But there's a lot of research going on. It's a really exciting time in terms of research about what can we do to be proactive with fertility preservation. At least like in my knowledge of the working group within the Children's Oncology Group, there's a big focus on that. So it's the short answer, it's a combination of both. And so I advocate for every single patient who's a survivor when you move into what we call kind of the survivorship phase of care to know what your treatment is. And that's a treatment summary so that you can get your survivorship care plan so you can have those discussions about I had, and it's really actually calculating how much alkylating agent, how many milligrams, per meter squared or, kilogram did I get? What was my radiation dose? Higher doses of radiation in certain locations can cause specific risks. So you have to know your treatment summary so you can have your survivorship care plan to understand that specific risk for infertility.
Thank you. Oftentimes, patients find it hard to find the right support groups. What kind of AYA cancer support is there for patients and caregivers?
Here at UCLA, we do run an AYA support group that meets once a month on the second Tuesday of the month. And then we're fortunate here in Los Angeles that many of the supportive, the cancer support community runs AYA support groups. Spark in the Valley runs an AYA support group. Cancer Care, which is based in New York, runs an online support group for AYA patients. LLS has AYA support groups that are online. My piece of advice that I always tell to anyone is you should go in with an open mind and try it out. Sometimes you might need to go twice before you can really feel comfortable. Most AYA support groups are open groups, meaning that it's not a closed session where you have to come for 6 weeks straight. So the first time you go, you may see people that you saw in the waiting room of your oncology clinic, and then the next time you go, it might be a different group of people. Another piece of advice would be to call the person's name that's on the website or the flyer to get information, whether it's a processing group or it's peer support. But again, just to go with an open mind and know that everyone's experience is going to be different, despite the fact that, yes, they're a young adult who had cancer and has had similar life experiences, but even as you heard tonight from our panelists who came with very similar stories, they had very different experiences.
Can I add to that?
Yeah.
So there's that, and then there's also, which I utilize, there are Facebook groups. So it's like not even having to leave, and also you have people from all over the world. Like I was able to interact with people that live in the UK, and it was really interesting to learn about their healthcare process there. And so it's not, we don't have the same exact stories and the same exact treatment and everything, but I found that to be really helpful. That was like a thing that was just always there on my newsfeed and in a private group to just have.
And what about on the side of caregivers? So are there any platforms available for medical professionals?
Medical professionals to get?
So medical professionals are and parents as well, like caregivers.
So the organizations I all list also provide caregiving support groups. And they have both in person and online for most of them. And I also do believe Facebook also is amazing in the sense that they have disease-specific caregiving, correct me if I'm wrong, support groups. It's gotten very creative with how they go. Yeah. At this time, we do not have an AYAA-specific caregiving support group, but that is something our program is hoping to have, hopefully maybe even before the end of the year.
For young professionals, how do you help support potential changes to health insurance while navigating a cancer journey?
So I didn't have insurance when I moved out to LA. I got it while I was out here because I was transitioning from, being on my parents and then being on my own and making sure that I had insurance to cover me while I was in LA, and also maybe if I were to go home and visit my parents. So I got insurance through the Affordable Care Act, something that I could afford as a college student. And yeah, that was what I had to do, and it was a process, and I definitely learned a lot about insurance when I was diagnosed and how to, make a claim and pay it off and things that I never thought I'd need to know at 21 years old. But and then when I transitioned into having a career, happily, luckily, yay, I have insurance through work, which is really incredible, and I'm very grateful for that. And yeah.
Great. What impact does strict compliance and adherence to treatment have on outcomes, and what factors play into that?
I can speak a little bit to that. I mean, what we know is that a lot of the studies that we've done in pediatric and adult oncology show that obviously the more compliant you are with your medications, the more likely you are for survival. And so that's just plain and simple. And we know that there are a lot of issues related to compliance. And one thing that we've had to do with this specific population is find out what are the barriers to poor compliance for them. I think and this is something that I think providers, we've done a really bad job at, is that we just label the AYA population as non-compliant, as this kind of like catch-all, like, oh, they're just non-compliant, they don't want to take their medications. And I think what we're realizing is that that's definitely not the case, that there's a lot of reasons for non-compliance. Maybe they're just not aware that, the importance of these medications. Maybe going back to that insurance issue, maybe they don't actually have access to those medications. We make a lot of assumptions, and we also don't really, I don't think, provide the best instructions when we're informing patients on what they need, why they need it, and really enabling them to kind of better take care of themselves. I think that's one thing that as a health system we really need to improve upon is not just labeling people as non-compliant and saying, oh, this is your problem, you're being non-compliant, but saying, how can we as the healthcare system better enable you to be compliant? How do you better understand compliance? How do you understand the importance of your medications? And then how do we figure out ways that you can take your medications? There are young adults that still can't swallow pills, and maybe that's their reason for non-compliance, and we need to help them through that. Or, just need that reminder. So we need to help them with digital apps that will help them with kind of, making sure they can be more compliant with their medication. So, to end that, we know that compliance is huge. It's super important to this population. And we also know that we have to, on a very specific level, better understand reasons for issues with compliance for this AYA population.
So the info projected on the slide currently is from 1997. As there is now more data about the AYA population, how has the gap seen on this slide changed since 1997?
We're really fortunate here in LA because Dr. Dennis Deepin, who's actually out of USC, he's done a lot of basically kind of the big databases looking at outcomes. So for certain areas, we've actually made improvements, and this data continues to be analyzed. But for certain things like cervical cancer, which is one of our AYA diagnoses, we're actually seeing improvement in certain rates in people. In other areas, we're seeing that there may be worse outcomes, like colon cancer is very rare in AYAs. It's common in older adults, but we're seeing that they can have, lower survival rates, and there could be multiple reasons for that. So there's ongoing, data analysis that continues to come out every few years, looking at the survival rates with all the different data. I think also many times this is also another area that I think is so critically important, is who's in our samples. In California, we're unique because we're a very richly diverse population. And so are those outcomes the same across all race ethnicities? We know in our pediatric oncology trials that we have seen differences in survival based on whether you're non-Hispanic, white, or Latino, and it gets back to the compliance question. This wasn't a pediatric studies, but they were just trying to understand why, if you got all the same chemo, you would have a lower survival rate if you were African American or Latino. And in one, kind of critical study, just looking at compliance, like you had to be compliant with your oral chemotherapy, and for certain regimens, you could be taking it up to 3 years. And think about taking these meds every day for 3 years. It was it drug metabolism? Was it not taking the medicine? And one study showed it was like if you weren't compliant 95% of the time, and again, this is coming out of the children's oncology group, but you would have a lower survival rate. And so I think that we're going to have, continued opportunities. I know at the national level on the pediatric side, we continue to look at ways that we can analyze the data and see how we can improve those outcomes. But I think it's going to be a changing landscape. So we're doing better in some areas, and then other areas are opening up that clearly show that we need to improve for all our patients.
How can the staff here at UCLA get more involved with this AYA group?
No, I mean, I think one of the big initiatives with kind of revamping the AYA program here at UCLA was how do we engage the greater UCLA community and the health system and the community within Los Angeles. And that was a huge initiative that we really took on, is that we said we don't want to reinvent all of these different service lines here at UCLA and the community. We have such a rich group of resources in the community and here on campus, and it's how do we engage those different services. And really what we wanted to do is within the AYA program, and why we brought Julie on, it's been such a huge asset, is how do we streamline those services? How do we make sure that we are aware of what is available in the community and here at UCLA? And we're always looking for collaborators, and we're always looking for different needs, and how do we address those needs in novel and interesting ways, both in the community and here at the UCLA Health System. I don't know if you have anything more specific.
There's a sign-up.
Oh yes, there's a sign-up sheet. So yes, please. And in general, one of the big pieces, and it gets back to some of those resources in the community, is we've really tried hard, and we're continuing to try to revamp our our marketing material, and really make a very robust online presence that will kind of catalog a lot of these different resources for anybody, not necessarily even within the UCLA Health System, but more broadly, so they can have a streamlined service of what are those resources out there. And places like LLS and TCA have already some great resources out there, so I'd continue to advocate people to go to those resources as well.
Thank you. And the last question for the night. To all the panelists, what hopes do you have for the direction of cancer treatment in the future, and what exciting things do you see happening right now?
When I think about cancer treatment for the future, I think about this population specifically, and I've learned so much from these patients, and I just think of them as a voice for change and changing and improving the care of how we specifically treat AYA patients. And so whether that's how the word adherence is attached to this population, that oncofertility is just part of care when we think of, in 5 years from now, any patient that comes through the door between the ages of 15 and 39, that is just an automatic consult, and it's covered by insurance. So that's where I see, and I really think that this patient population is a voice for change, because they are advocates, and they're so embedded in being autonomous young adults with goals, and their goals need to be heard, and that's what our program echoes, and we want to hear what their goals are and make sure that we're making sure everyone on their medical team hears that.
I think it's a very exciting time across the board for oncology care. I think the amount of new novel therapeutics is truly incredible. And what I hope for the future of therapy and really for cancer care is that this, this graph above continues to go up, but it goes up across the board. I want to see those, rising improvements in survival really across the board for all of our different age groups and age populations. And how do we make sure that happens? And it's really through advocating for this age group. So really kind of delving into what are those needs and how do we make sure that their survival advantages start to improve alongside with our pediatric and older adult populations.
For me, I'm most excited about opportunities to continue to get access to clinical trials for our teens and young adults, because just echoing everything that Dr. Spiker said, we're in a really exciting time with targeted therapies, whether it's adding on a monoclonal antibody to a patient who has to get very aggressive chemotherapy for Ewing sarcoma, or adding on a monoclonal antibody for someone who has Hodgkin's, or leukemia if you have a specific marker on your tumor cells. So my hope for that is as we continue, I don't, necessarily think there's going to be one magic bullet like I see things online, but I think this combination of continuing to have targeted therapies in combination with our chemo, so that it ultimately not only increases our chances for cure, but also decreases these risks for late effects. We're gearing up for a big national study submission looking at long-term effects, and now we're saying, if we get this grant, where are we going to be in 5 or 10 years? What are the late effects of these targeted therapies? And our hope is that if we can get targeted therapies, we can decrease some of the toxicity from kind of our standard, tried and true, very toxic chemo regimens or radiation, or can we not give radiation? So ultimately we have less late effects, so there's less health problems for our cancer survivors, as well as continuing to increase the cure rate.
The hope that I have is that we get to learn more about this population from their stories. It's very exciting to have AYAs come and share and give a different perspective that's not always so bleak, but can be very rewarding in some weird way that cancer has opened doors. And as Dr. Casillas mentioned, with all the targeted therapies that we're giving, we're trying to move a lot of our therapies that become much more functional on the outpatient arena, so that we can have our AYAs not be secluded in our hospital settings, although that still might be a reason for them to sustain treatment, but so that we can build compliance around the AYA population, so that they can see outcomes sooner than later and know that it's worth the while when it comes to seeing those little wins, and that there is more out there to explore, and it does open up opportunities. I always get intrigued that we thrive on AYA research and all the fundraising that we do to build more research, so that we can shout more about AYA, and that it's not just a secluded population that you see up here, that we become more of a pattern of improvements and outcomes, and in a way invite more healthcare professionals to enjoy this population, because that too has been something that has not been formally, or especially in my training, as a common population. And now in the curriculums that we're actually seeing that AYA does comprise its own course and its own ideas that we need to build on. So it's a very exciting time for us, especially here in America.
Yeah, where I see the hope, I would say, is that there are stories like ours where we're not only surviving, but we're thriving. And cancer is just a part of our story. It's not the entire story. And I think with what all the medical professionals were talking about, that all these medical advances, this exciting time that it is right now, that there's going to be more of those stories. And just kind of the hope is that a larger percentage of those AYA patients that are diagnosed can have stories like ours, in which they kind of get back to normal life and making a positive impact.
My hope is that this conversation keeps happening, and that we are talking about the psychosocial and also, the research and the treatment. And my hope is also for less toxic and more targeted therapies. And then the follow-up was, what do I see happening right now? I see that. Like, events like this give me hope that that's happening. The fundraising and work that I do with LLS shows me every day all the FDA approvals of the less toxic and more targeted treatments. So I am really hopeful about the moves that we're making here, and I'm very grateful for it. And since I'm last, I'm gonna go rogue real quick. At the end of all of my videos that are all on YouTube, I always end with my mantra, which is everything's gonna be okay. And since I guess this is ending, could we all stand up and do that? Can we all go, everything's gonna be okay, and move forward and make all of our hopes and wishes come true? All right, 1, 2, 3.
Everything's gonna be okay.
Yay! Thank you so much.
I'd like to thank all of our amazing panelists for taking time out of their day to come to this event. Let's hear it. Another round of applause. I'd also like to thank all of you for coming tonight. The panelists will be around to talk to one-on-one, and there are currently handouts highlighting UCLA resources available that are coming around and also available at the front entrance. Thank you all again.